practice today doing our lecture on compliance. I'm sorry, I will have that the PowerPoint still up, but tomorrow I'm planning on actually redoing it, so it just sounds a little bit, so it's a little bit more smooth. So hopefully today's lecture will go a little bit better. It is still Thursday and I'm recording this for Friday, so for our first recorded lecture. So this will be for day 2 for Friday, September 4th, and we'll be just kind of talking about ABGs, all the different values, kind of talking about respiratory acidosis, alkalosis, all that good stuff. So again, some of this should be review, but we're just kind of hitting it again. So I'm just out of practice. I've had a little bit of time off of not teaching, so I have to get back in the groove. Alright, so we should have these normal values ingrained in your head by now. If you don't, please do whatever you have to do. Sleep with them underneath your pillow. Have osmosis or something so you have these values, so you have these memorized. Okay. Alright. Okay, so we're first going to just talk about respiratory acidosis. Okay, so that's kind of something that we can hopefully intervene with, kind of more like our fault, I guess. If you look at a blood gas and figure out if it's alkalotic or acidotic, and then if it's respiratory, then hopefully we can do some interventions to help correct it. So an acute process obviously is something that's happened rather suddenly, with the pH on the low end, less than 7.35, your CO2 is high, generally have a normal PaO2 and a normal bicarb. So some of the causes, so I want you to memorize or know these: hypoventilation, related to drugs, could be one of them, or it could be something going on with the head, like a trauma to the head. Sedation, because all those types of things can basically lead to hypoventilation. So that's kind of like your primary reason. We're obviously not getting rid of our CO2, and of course a code situation. And then your chronic respiratory acidosis, your pH again is in the normal, or this time not, it's in the normal range rather, and then your bicarb you're going to find is going to be high. Your CO2 obviously is also high, but your bicarb is high. So the biggest thing with the chronic respiratory acidosis is that your pH is in normal range, okay? And so your CO2 is on the high end, like an acute process, but your bicarb is helping buffer so that you can maintain that normal pH. And a lot of times that your PaO2 is low during your chronic respiratory acidosis. Causes restrictive disease, obviously COPD probably being one of the more common ones that we see practicing as respiratory therapists. Muscle wasting, neurologic disease, neuromuscular disease, and Pickwickian syndrome, obesity. Acute airway obstruction can actually have a, I'm just looking at this, I have a note here. Acute airway obstruction is going to, initially you may have a lower CO2, but as you start to fatigue, then your CO2 is going to go up, and then as you get into that later phase, then you'll develop a respiratory acidosis. Okay, so this is some of them again, kind of listed. This must be an old screenshot because this is actually in chapter 14 in Egan's book. So that's why I had to pause you guys for a moment and double check this, but this is chapter 14 in Egan's, which is what is listed for the reference textbook for this particular PowerPoint. So again, as you can see, the late phase there of acute airway obstruction can lead to respiratory acidosis, along with those other things listed there. So be familiar with those. So respiratory acidosis, obviously we're hoping that that we can intervene, bring the CO2 down in a chronic situation. Hopefully the bicarb can help us out by reabsorbing, and the bicarb will become elevated, which will help normalize that pH. So if your bicarb is elevated and your pH is improved, so it's within the normal range, and you can see the bicarb kind of going up, then you have a partial compensation. When you have a full compensation, then that's where the pH is restored to normal, and again your bicarb is elevated. So your overall goal obviously is to improve alveolar ventilation. Okay, so whatever it takes, you know, whether we need to intubate the patient, do non-invasive, you know, even improving bronchial hygiene, somehow, you know, just able to help them breathe better. In a chronic condition with renal compensation, you have to be careful that we don't overcompensate by lowering the PaCO2, because the body has adjusted over time, so we have to be careful with those chronic retainers with high bicarb levels, that we don't blow off too much CO2 when they're on the vent. Alright, respiratory alkalosis. So that is when we're basically have overventilated. Okay, so our pH is on the higher end, our CO2 is low. In an acute situation, we have a normal PaO2 and a normal bicarb level. Again, hyperventilation, so that we've basically hyperventilation should be defined as an abnormal blood gas versus just, you know, observing somebody and thinking they're hyperventilating. One of your most common causes, though, can be hypoxemia. So you may actually see a low PaO2 in that case. There could be other things, pain, anxiety, encephalitis, so any head injuries. We'll often see that in head injury patients on the ventilator. No matter what we do with them, they're just breathing at a fast rate, no matter what settings that we have them on. And so that's related to, you know, a brain injury, especially closer to the brainstem. Cirrhosis of the liver, a PE, which obviously is going to lead to hypoxemia, an infection, a fever. So don't forget the fever, because sometimes when you do your assessment on a patient, you can't really figure out any other reason as to why the respiratory rate has gone up. You also notice that their heart rate's gone up, you know, everything checks out okay with the vent, and chances are they're spiking a fever. And then when we look at the other of chronic respiratory alkalosis, again, you're going to see the low PaCO2. Your pH is kind of normalized out because your bicarb is also dropped, and probably really the most likely thing is long-term mechanical ventilation. Something, you know, that we do see if we're overventilating a patient. All right. So again, it's alveolar hyperventilation, lowering the CO2, which then decreases the carbonic acid, which then leads to increasing the pH. So any process that would increase alveolar ventilation brings down that CO2. So this is pretty much repeating the slide before. Also talks about paresis, early paresis. That's kind of like they may show signs of that, which basically is numbing and tingling feeling. Okay, that's what that means, parethesis. If it's severe, you might have hyperreactive reflexes, where you might be kind of like having like little spasms, kind of twitches. It can also lead to tetanic convulsions, and associated with dizziness. So people that are actually like having a panic attack, you know, they may have them rebreathe their CO2 in a paper bag or whatever, but they may experience some of these other clinical signs where they feel numbness and tingling, they feel lightheaded, they might start twitching really bad. So, and just make sure it's not due to hypoxemia, because it could be corrected by just giving them some oxygen. All right. So basically we want to just remove whatever is stimulating their hyperventilation. So again, if it's hypoxemia, give oxygen. Alright, our metabolic acidosis. See, I told you guys this is kind of review stuff. Metabolic acidosis. So now it's really not our fault. Your bicarb's low, okay? So you'll have a normal PaO2, a normal PaCO2. Your pH though is low, and it's generally your bicarb reason. So that's why it's metabolic. And we'll see these in our DKA, diabetic ketoacidosis patients, renal failure, and with severe diarrhea. So you may get called to the ER to do a blood gas on a, looks like a totally normal, healthy kind of person. They may be younger, and you're like, why am I drawing a blood gas? They're not even on any oxygen. Chances are they're a diabetic and they're ruling out for DKA. And it's okay if you ask that. Just say, are you by chance diabetic? Most likely they'll say yes. Sometimes it's the first time they've had this incident of it, and so you may educate them on that, like, oh, where they're just checking your one of the levels in your blood to see what's going on and why you're feeling this way. So compensated metabolic acidosis, then our pH is in the normal range, and a normal PaO2 rather. Your PaCO2 is low because we are trying to help compensate for that bicarb. So we're going to blow off some CO2. So a chronic respiratory compensation can be a reason for a compensated metabolic acidosis. Keeping in mind, the compensated metabolic acidosis is something that you can also easily fatigue from if you're kind of hyperventilating, basically to bring down the CO2. So you'll kind of see it more so really in patients with more chronic also renal issues. Okay, so again, what's happened here is we have the low bicarb level leading to a low pH. Some of the causes I kind of mentioned already, but a little bit in more detail, is increased fixed, remember, or non-volatile acids build up in the blood, or you've had an excessive loss of bicarb, like in diarrhea. So back to that increased fixed acid accumulation, that might definitely happen in where there's a low flow of blood, low blood flow to the tissue, due to which can lead to tissue hypoxemia or hypoxia, and then have anaerobic metabolism, because remember, anaerobic metabolism then produces that lactic acid, which can then increase the acidosis. So we have increased fixed acid or non-volatile acid accumulation, or excessive loss of bicarb due to diarrhea. And we'll talk about the anion gap here coming up, and that can help identify what the cause of the metabolic acidosis is. So actually we're talking about a little bit sooner than later in this particular slide. So an increased anion gap metabolic acidosis, so the normal anion gap is about 9 to 14 milliequivalents per liter. So as the fixed acids increase, they dissociate and the hydrogen binds with the bicarb, and that leaves an unmeasured anion behind, which then increases the anion gap. And I've got in a couple slides I do actually have more of a picture about this kind of from Egan, kind of helps explain that a little bit. So a normal anion gap, what happens is the bicarb loss doesn't increase the gap, because you have the anions, which are your negative electrolytes, and your cations are your positive. So what happens is there's kind of like the chloride then offsets the loss of the bicarb, and then that creates more of a normal anion gap. So you'll see an elevated chloride level. So it can also be called hyperchloremic acidosis. So that's kind of helped offset that increase, or helps offset the anion gap, basically. All right, metabolic alkalosis. So in this case, we're going to have the higher pH, and so we know it's an alkalosis. The bicarb is going to be elevated, so we know it's not respiratory's fault. We have a normal PaO2 and a normal CO2. Some of the common causes can be vomiting, losing that acid, prolonged or increased nasogastric suction, steroids also. Oops, I got a little typo there. Compensated metabolic alkalosis, that blue title there should go up on the top. I was trying to make that little, move that little diagram there a little bit. So the compensated one, I'll fix that when we're done here. You'll have the normal pH because you're compensated. Your PaO2 can be low, and again your CO2 is going to be high along with your bicarb. So hypokalemia with dehydration. And so we have to be careful with hypokalemia because that can lead to some cardiac issues. Okay, so we have some EKG changes, and we'll talk about that in a couple slides here coming up. I have two computers up at the same time, and I bumped the wrong mouse. So I just wanted to talk a little bit about this slide again with metabolic alkalosis. And again, this is covered in chapter 14 in Egan. So some of the compensation then is hypoventilation, even though you're hypoxic. Okay, so metabolic alkalosis blunts the hypoxemic stimulus to ventilation. The neurologic receptors that are sensitive to hypoxemia become less sensitive in the presence of alkalemia. So patients with a PaO2 levels of 50 may actually still hypoventilate to CO2 levels up to 60 to compensate for that metabolic alkalosis. However, significant CO2 retention is generally not seen in these cases of metabolic alkalosis, probably because the metabolic alkalosis commonly coexists with other conditions that may cause hyperventilation, such as anxiety, pain, infection, fever, or even pulmonary edema. So the correction is to hopefully restore the fluid volume, the electrolyte concentration of the potassium and chloride levels, and even in some cases, if it's really severe, they would actually give a very dilute hydrochloric acid level into a large central vein. Now, I hope I don't have recording on this because I actually bumped my, hopefully we have an overlapping recording because I actually definitely bumped my mouse. So this is just kind of what happens with the compensatory mechanisms here of your sort of a rule of thumb. Have you with an acute respiratory acidosis, so your PCO2 would have to go down 10 millimeters or 10 torr to get your pH to go up 0.1, and then your PaCO2 would have to go up of 20 to bring your pH down of about 0.1. For your chronic respiratory acidosis, your PaCO2 would have to go up 10 to equal either 2 milliequivalent per liter, which is listed for pill beans, and 1 milliequivalent per liter for Egan. So either one. I don't really recall there being any exam question on this, but just so you know how these compensatory, what kind of the trade-off basically of helping to normalize the pH. So just be kind of, be familiar with them. Alright, so what I was referring to before is if your potassium level is low, So we have to be mindful of that we can have EKG changes. So basically it results in a delay of ventricular repolarization. And we'll talk more about this in CV diagnostics too. So, so you're looking at the ST segment, the T wave, and U wave abnormalities. So chronic hypokalemia can also cause myocardiofibrosis. Can also lead to skeletal muscle weakness, cramps, and then respiratory failure if it keeps up. Also can have smooth muscle constipation, urinary retention, again the prolonged repolarization of the Purkinje fibers, and if it's bad enough, VFib can actually develop. So that's why it's important to always check those electrolyte levels too. Alright, now we're going to talk a little bit about the anion gap here. So again, using the anion gap, or looking at the anion gap, can help distinguish the cause and the diagnosis of why you have a metabolic acidosis. So when ABG is drawn, they're usually doing this other labs to help look at the patient's electrolytes. We're looking at sodium levels, the chloride levels, the bicarb levels, and this is basically the equation to figure out the anion gap. So you look at your sodium and you subtract the adding the chloride level and the bicarb level together. So you would take 104 plus 24, which would give you 128. If you take 140 minus 128, you get 12, and that would be considered a normal anion gap. So 12 is a normal plus or minus 4. So I guess you got a range of about 8 to 16. Yeah, 8 to 16 there. So increased anion gap greater than a 12 to 16. I mean, it just depends on your lab basically. I've got a 12 to 16 is considered normal by Egan, or no, normal by pill beams, and then Egan says 9 to 14. So again, depends on your resource, depends on your lab. So again, if you have a greater level, that means the acidosis is due to the addition of acid in the blood that's generally metabolically produced. So an acid gain can be like a lactic acidosis, a ketoacidosis, renal failure. We'll kind of address that a little bit more on the next slide too. A normal anion gap, or you might hear it referred to as a non-gap, means that the acidosis then is due to the loss of bicarb. Okay, and a decrease anion gap occurs with hypoalbuminemia. Albuminemia. I always think that's a funny word to say. Okay, so remembering that we want to try to keep this law of neutrality basically, law of electroneutrality. So we want to kind of keep everything more or less even, kind of balanced basically. For some reason I'm at the loss of words. I'm having a rough day today talking. So we want to keep everything like homeostasis basically is what I guess I'm trying to say. So the law of electroneutrality states that the number of positive charges has to equal the number of negative charges in the body's fluid. That's when everything is happy basically. So normal plasma concentration of these electrolytes are that the cations, okay, so your cations, your CATION, those are your positive ones, and that's your sodium and potassium, outnumber the anions, which is your chloride and your bicarb. Those are your negative ones, and this is what leads to an anion gap. Okay, so we have an offset of these different numbers here. And this is the picture that I was referring to that comes out of Egan in chapter 14. So basically you're looking at a normal value here on your left side where all of your levels are in normal range. Your sodium is in normal range, your chloride's normal range, your bicarb's 24. So your anions and your cations are the same amount, and your anion gap being 11, which is normal. Okay, so when you have a metabolic acidosis, so when you actually have an anion gap on the middle one there, you can see how the chloride is still 105, your bicarb though is 12, and your anion gap is 23. Okay, so you have an increase of that anion gap. Those unmeasured anions then are 37. Okay, so you're still equaling out, but your bicarb level is low and your chloride level is normal. Then on the far right side, so basically, so your anion gap is normal, and then in B and C you have a metabolic acidosis. So you have fixed acid accumulation increases the anion gap in B, so in the middle one. Whereas the bicarb loss on the far right side, you still have that bicarb of 12, but it is kind of offset by a gain of the chloride. So you can see that the chloride goes up to 117, which then keeps the anion gap in normal range. Okay, so it kind of has like a trade-off. It kind of replaces that negative. So you still have 154 on the bottom of each of them, but you've been able to kind of compensate basically. So an increase in the anion gap, so greater than 14, is caused by a metabolic acidosis, where the abnormal fixed acids accumulate in the body. The hydrogens of these acids react with the plasma bicarb, lowering its concentration, which then leads to a further increase in the anion gap, or an increase in those unmeasured anions, like you can see in the one in the middle there of 37. And that can be caused by lactic acidosis, ketoacidosis, renal failure. A normal anion gap means that the acidosis is due to the loss of the bicarb, does not cause any further increase in the anion gap, because the bicarb loss is offset by that chloride gain, which then helps keep the anion gap within normal limits. So it's important for them to look at all those lab values to kind of help determine really what's going on with the patient. Okay, hopefully you're not totally confused. There's a lot of information there. So again, trying to determine if it's a gap or a non-gap, basically, or a normal gap. So this is kind of talking about how on this one we do have anion gap here. So this is a gap metabolic acidosis. Our chloride level hasn't gone up, and we have a gap of 34. Okay, so this can be caused again by the increased acid, the lactic acidosis, or ketoacidosis. And then this is the one where it's kind of showing basically you have the chloride level has gone up to 124 there, so now you have a non-gap acidosis. So the chloride's kind of helped offset that. Okay, so again, decreased bicarb in the blood, diarrhea, renal tubular acidosis, and not an addition of acid. We have the same ABGs on those, but different causes. And unfortunately, I can't go back on my slides because when you're recording, it just won't allow you. So we were able to narrow down that the metabolic cause was from the electrolytes. So that other one had a low, I'm trying to look back at my slides here, the other one had or my paper had a low chloride level then. So if you're able to compare both of those slides or pieces of paper, or however you do your setting, again, you're looking at, you have both of the blood gases are a 7.10, your CO2 being 14, and bicarb should be 4 there. That's not a -4, that's just a dash. And then your sodium here is 140 and chloride's 124, where on the other one same pH 7.1, CO2 14, bicarb 4, but your sodium was 128 and your chloride was 90. So that had the anion gap of 34. So just so you can kind of see the difference between them. Alright, so when we're looking at base excess, so base excess is generally either plus or minus 2 milliequivalents per liter. So base excess is basically defined as the amount of hydrogen ions that would be required to return the pH to 7.35. Okay, so base excess is defined as the amount of hydrogen ions that would be required to return the pH to 7.35. So positive base excess, so greater than positive 2 milliequivalents, indicates a gain of a base or a loss of an acid from non-respiratory causes. And then a negative base excess indicates a loss of a base or a gain of an acid from non-respiratory causes. Then Ian goes into great detail on this, but we're just talking about it kind of for, trying to keep it in the back of your mind when you're looking at ABGs. Now, the next several slides is going to be talking about ionized calcium. And so you know that calcium, when we're looking at calcium, ionized calcium, we're really talking about free calcium, because calcium, serum calcium, kind of can break up into like 3 different types of calcium, if that makes sense. So you have a serum calcium, and then it branches off with your ionized calcium, which is your free calcium, and that's what we're going to be talking about. The calcium that is bound to anions, and then a calcium that can be bound to proteins. Okay, so ionized calcium binds to negative sites on protein molecules. It competes with the hydrogen for sites on the albumin. So binding is pH dependent and alters the level of calcium in the blood. So if an increase in your pH is going to increase your protein binding, so that part of the calcium is going to be higher, and decreases the free calcium level. Your lower pH, so if you're more acidotic, is going to decrease that protein binding and increase your free calcium level. So the normal, again, this is referring to free calcium. The normal level then is about 4.4 to 5.4 milligrams per deciliter. It's just another lab that they'll look at, and I'm just going to kind of briefly go over this. Don't get too freaked out about it. You may have like 1 or 2 tests. I can't even tell if there's much on the boards about it, but if we have a really low calcium level of less than 2, that can be considered to be life-threatening. Okay, so you can kind of freeze up. That technique would be like freezing up your that's actually kind of interesting now that I'm talking about this, because Bear, our dog, he had to get weaned early from his mom because she had a really like a life-threatening calcium level. For some reason her body wasn't producing enough calcium. She had to quit nursing early, and she was to the point of not being able to walk. So she had, probably, I don't know how animals work, but she had a really low calcium level. If you have a higher calcium level, that can lead to a coma. So if you're looking at ionized calcium, again, the free calcium, if you see if it's low, these are some of the different things that you could consider the reasons. You can have an acute or a chronic respiratory alkalosis, hypoparathyroidism, hyperventilation. High IACPs are going to make you normally hyperventilate. Sepsis or respiratory failure, bicarb administration can bring the calcium low, renal failure, cardiac failure, burns, toxic shock, fatty embolism, DKA, sepsis, acute pancreatitis, basically from those drugs. And if it's elevated, then you're looking at hypoalbuminemia, acidosis, parathyroidism, sarcoidosis, drugs, TB, kidney transplant, use of thiazide diuretics, overdose of vitamin D, and alcoholism. So those are things that would throw your calcium levels out of, or could be reasons why your calcium level is out of whack. So drugs that actually increase, again, then are those thiazide diuretics, hydralazine, lithium, thyroxine. Drugs that can decrease your calcium, heparin, lipids given via IV, epinephrine, norepinephrine, alcohol, and isoproterenol. So just kind of, it's basically looking at the calcium levels, another piece of the puzzle of trying to a diagnostic tool. So basically, what does this all mean? And I have a little scenario to kind of talk about here. So you're at a code blue of a 5-year-old in the ED, and you're doing CPR, you have the airways in place, you have ABGs with labs are obtained, and the child was known to have a seizure, vomited, and stopped breathing. Here are your blood gases and some of your lab values. So you have obviously a metabolic acidosis and with some respiratory because your bicarb's only 18. Your calcium is 10, which is big time elevated. Your potassium is 4. So your potassium then is 4, which is normal. So what do you think could be the actual cause? So the possible cause for this is probably a overdose of a calcium channel blocker, which is a medication that someone at home maybe is taking for their blood pressure, so it's going to lower obviously the kiddo's blood pressure and put them into a rest situation. Pretty sure this was like a little Derek scenario here. The big takeaways that I want you to know here about calcium is that there's a direct, if you look at the middle paragraph, there's a direct correlation between the duration of resuscitation, low serum ionized calcium levels, and mortality. However, high plasma calcium concentrations after exogenous calcium injection may promote myocardial damage and impair neurologic recovery. Improved survival was suggested by case reports of calcium use in children during cardiac surgery. However, studies of calcium during cardiac arrest failed to demonstrate any benefit on survival. So it's really not recommended. In your last paragraph there, the calcium is really not recommended for treatment of cardiac arrest, so it's considered a class 3. Administration of calcium during resuscitation is considered only if specific circumstances such as hyperkalemia, low calcium, and an overdose of calcium channel blocking drugs. Okay, moving on. Talking a little bit more about the acid-base balance, which is going to lead us into talking about our O2 dissociation curve. So remembering respiratory acidosis, we have a PaCO2 again greater than 45, our pH is less than 7.35, so we're having inadequate alveolar ventilation. So what we need to do to correct it is to increase our minute ventilation. Okay, patient anxiety may cause ventilatory asynchrony, so we have to make sure that we're on the right mode, the right tidal volume rate, eye time flow, all that, and obviously sometimes a little touch of sedation is going to hurt to make sure that these patients are synchronous so we can optimize our ventilation. Sometimes if we have too small of a tidal volume, We're obviously going to lead to more increased dead space. Patients might, have difficulty then and have a respiratory acidemia. So we just, kind of have to make sure that we've have done the best for fine-tuning our vent settings. Then our respiratory alkalemia, we have too much alveolar ventilation going on. We need to decrease the minute ventilation. And again, it can be pain, anxiety, it could be fever, it could be head injury. So we need to do something to correct that minute volume setting. And it's important because these acid-base status impact the electrolyte balance and our oxygen dissociation curve, or oxyhemoglobin dissociation curve, which actually affects the loading and the unloading of how we're going to utilize that oxygen. So that's why the acid-base status is important. So you probably remember this lovely curve again. There's a couple things I want to talk about as far as estimating your PaO2. So there is like a little estimate formula. There's a couple of them here. You can take 104.2 and subtract 0.27 times your age. Take that value and subtract it from 104.2. Or you can also do 105 minus a quarter of the age to approximate. So let's say you were trying to give an easy number. A quarter of 60 would be 15. So that would put what our PaO2 at. If you're 60 years old, your PaO2 would be like 90 at sea level. Am I right? 15? Yeah. So just an approximation. You can also look at the PaO2 to SpO2. I know I mentioned this before to one of the other classes. They didn't really seem to remember this or be familiar with it, but the 4, 5, 6, 7, 8, 9 rule. So that basically means if your PaO2's in the 40s, your SAT's probably in the 70s. If your PaO2's in the 50s, your SAT's in the 80s. If your PaO2's 70, your SAT's about 90. So kind of lining up those numbers. 4 with 7, 5 with 8, 7 with 9. I'm sorry, 6 with 9. So again, 4. So PaO2 in the 40s, 70%. PaO2 50, 80%. PaO2 60, 90%. Approximate. Okay. So one of the things, a little acronym to kind of remember, if we're shifting to the right, okay, if we are shifting to the right, you could remember, so that's called the Bohr effect, if you're shifting to the right. And a little thing to remember is cadet face right, okay, so cadet face right. So basically, you have C-A-D-E-T, cadet, like an officer or whatever. So cadet face right, like saluting face right, salute. So you're looking at C standing for your CO2 is going to go up, okay? So CO2 rising, which causes the A for the acidosis. D is the 2,3 DPG, because there's a 2,3 BPG and then also 2,3 DPG. So that's for the D. E would be exercise. When you exercise, you're going to release more CO2. And then temperature, okay? Obviously temperature, anything that's going to increase the metabolic process, basically, okay? So you're releasing oxygen to the tissues, okay? So that's your cadet face right. So that's the way to kind of remember what's happening when the curve shifts to the right. So C-A-D-E-T. So the Bohr effect then basically enhances oxygen loading to the lungs and unloading to the tissues, okay? Things that would shift it to the left then would be kind of the opposite. So your decreased temp, your increase in your pH, decrease PCO2, and then fetal hemoglobin. Those are things that shifted to the left. So when we're talking about, again, the Bohr effect and the Haldane effect, so I'm going to talk about the Bohr effect here first. So the Bohr effect is hemoglobin's oxygen binding affinity is inverse to the acidity in the CO2 concentration. So your CO2 / hydrogen are affecting basically the affinity of the hemoglobin to carry oxygen. And the Haldane effect is deoxygenation of the blood. So if your blood is low in oxygen, increases its ability to carry then carbon dioxide. And then conversely, oxygenated blood has a reduced CO2 capacity. So your oxygen level is affecting the affinity of the hemoglobin then to get rid of the CO2 or the extra hydrogen ions. So when we're looking at the Haldane effect, when oxygen sat increases in the blood, the CO2 content decreases at any given pCO2. So that low sat at the tissue increases the blood capacity to hold onto CO2 and helps facilitate the unloading of the CO2 into the blood at the tissues. The high sat at the lungs decreases the blood's capacity to hold on to CO2 and then helps facilitate the unloading of that CO2 in the lungs. Okay, so that's kind of how the Bohr effect and the Haldane effect work. And if we move on to the next couple slides here, you have a couple of video clips. Well, that'll definitely explain it with pictures and stuff. One is from Khan Academy that I really like, and the other one is from MedCram, in both of those. And I'll talk about those just a little bit more when we get onto those links there. So both the Haldane and the Bohr effect help facilitate the release of oxygen at the tissue and the uptake of oxygen at the lungs. Okay, so the Haldane effect and the Bohr effect are basically your right and left shift, or your left and right shift, sorry. Your left shift is your Haldane, your right shift is your Bohr. Okay. The Haldane effect then, again, deoxygenated hemoglobin has a higher affinity for the CO2 because it's a better proton acceptor than oxyhemoglobin. So then again, when the hemoglobin is deoxygenated, there's a right shift of the carbonic acid equation to produce the hydrogen, which then increases the CO2, which can be carried then by the blood to the lungs to be exhaled. Okay, that's kind of how it works. Then with oxygenation at the lungs, the CO2 then dissociates more readily from the hemoglobin. So that's kind of looking at the equation there. Don't forget our friend there, the carbonic equation, or the CO2 hydration reaction equation there. And then the other one is your Haldane effect. So I think if you definitely if you click on these videos, or the other way to view this, and I can't remember, I think we started, you guys were the ones, I was with you guys when we started with advanced patient assessment. So you're going to have this to listen to or do whatever you want. If you'd rather just read through it and do your own thing, that's fine too. I totally understand. I don't take it personal. It's hard for me to talk on the computer like this. I'd rather be obviously in the classroom writing some things on the board and answering questions and that. But shoot, what was I going to say? Dang it. I'll tell you, I'm having a heck of a day here. Yeah, so to get onto these links, you may have to go on just the regular view of the PowerPoint, how you just view it and print it from that view, or you can look at it this way. I'm not sure if these, when you're viewing this on the audio part, if it allows you to just click on it. So you might have to go back to Blackboard and just go through it that way. If you are looking at this on the first link rather, I would go ahead and kind of fast forward to about 3 minutes and on the first link, and then watch from 3 minutes on. You're welcome to watch those first couple minutes, but it really isn't what applies to us right now. So the first one is MedCram, and it's about 8 minutes, and then the second one is Khan Academy, which, you know, I always think he does a fantastic job. That's about 13 minutes. So I highly recommend you watch those videos. I think it really helps clear it up. I know it's a kind of a hard concept to grasp. I've watched him over and over and over again, and I've actually drawn out little pictures and stuff that he has done, and I think it's helpful to kind of go along with it that way. So moving on, trying to keep this under an hour if I possibly can. So we're looking now at differentiating between causes of hypoxemic respiratory failure. So really what's going on with our patients. So 3 main causes: hypoventilation, okay, so we're looking at a normal, the PA to little a difference, and we've got 10 to 25 being approximately normal, keeping in mind that gradient increases with age, okay. Also looking at VQ mismatch. If you have a VQ mismatch, you are going to have, it's going to improve with oxygen. And if you have a shunt going on, it's not going to matter. You're not going to have any improvement with your oxygenation. So trying to figure out why we're hypoxic. So your ADA gradient is basically showing the ability of to transfer oxygen from the lungs across the alveolar capillary membrane to the blood. Okay, remember our old friend here, the alveolar air equation? You'll be using this quite a bit again in CV diagnostics. So this helps to evaluate to see if we have a VQ mismatch, shunt, or some other hypoxemic secondary to hypoventilation. Okay, that's probably one of the more common ones. Again, your gradient, and it depends on your source. This one says 5 to 15 at 20 years of age on room air. That's like, you know, kind of textbook. Higher gradient, obviously, if you're on oxygenation. And the older you are, the larger the gradient. Okay, so this one says what, 30 to 60 or 65 on 100%, and then Egan says 100 to 150. So I mean, it just depends again on your source. All right, also looking at your little a to big A ratio. Okay, keeping in mind your normal is 80 to 100%. So what fraction of the oxygen is actually getting to the artery from the alveoli? Okay, so that would be your PA to A ratio then. Little a to big A. Normal is 0.8 to 1 or 80 to 100%. And then your P to F ratio, that's probably something you've probably seen a little bit more out there while you've been doing your clinicals, something that we definitely look at when we're trying to categorize what severity of ARDS is going on. Obviously, the lower the number, the greater the mortality. Kind of gives us an idea, you know, the severity of the lung damage. A normal would be 400 to 500. Okay, so this is really considered the most reliable index of gas exchange, especially if the FiO2 is greater than 50% and the PaO2 is less than 100. Okay, so you're definitely going to be seeing them referencing to this with your patients in the ICU. So kind of talking a little bit of the kind of the history of this, of the I feel really old when I look at this. It's like, oh, how they decided. Well, it was actually in '67 that Petty kind of had the definition of ARDS, but it's kind of relatively a newer term. The 1994 definition is kind of like I guess the most updated, where they decided to not talk about ALI or acute lung injury, but they're looking at different categories for ARDS, looking at the PF ratio. They're also looking at the X-ray, and another thing that they can look at is the they could, but they've removed it because we're not using wedge pressures anymore, but is the wedge pressure. So the definition of ARDS again is varied over time. Dr. Petty in 1967, in a case series of 12 patients, they shared this common features. They were very tachypnic and persistent hypoxemia, opacification on their x-ray, and poor lung compliance. So for more than 20 years, they really didn't have a common definition of ARDS. I think people just termed it ARDS, but it really wasn't until 1994 when we had the American European Consensus Conference kind of become up with this globally, a global term, which really wasn't that long ago. And then we have the current definition. The Berlin definition was published in 2013, and they are basically saying ARDS is an acute, diffuse inflammatory injury leading to increased pulmonary vascular permeability. So that's what makes the lungs kind of leaky and wet. So you have increased lung weight. They find that these lungs are really heavy. They have loss of aerated tissue with hypoxemia. They have bilateral radiographic opacities because their x-rays look like crap. They're whited out. They have associated with increased venous admixture, increased physiologic dead space, and decreased lung compliance. So that's the Berlin definition. Some of the things that need to accompany this definition is acute, meaning it has to be over the onset of 1 week of, it has to have happened over a week or less. This has to develop over that amount of time. Those bilateral opacities consistent with pulmonary edema must be present and may be detected. So you're having these wet lungs, be either detected on CT or X-ray. The PF ratio is less than 300 with a minimum of 5 of PEEP or CPAP, and it cannot be explained by being just a cardiac failure or fluid overloaded. So those things have to be ruled out. So again, the ability to predict mortality is rather poor. Generally, a lot of these patients end up developing multi-system organ failure, and if you have more than like 2 organ systems, your mortality goes up. If you have 3 systems involved, then it's even worse. So especially if you end up having to be on vasopressors at the time, you have a much higher mortality rate, regardless of whatever your PF ratio is. So if your blood pressure, obviously you're having cardiovascular issues, most likely your kidneys end up being affected, and you're kind of starting to get 1 foot towards the grave. There is kind of a harsh way of putting it, but unfortunately it's true. So the 4 variables of severe ARDS were assessed, but don't have really a predicted value. Looking at how severe the x-ray is, compliance of less than 40, your PEEP is less than 10, and you have a higher minute volume greater than 10. And unfortunately, I'm sure with these COVID patients, you're seeing quite a bit of this. And then we're going to leave with this last little slide here, and we'll be revisiting this a lot more again in CV diagnostics, calculating your CaO2, your oxygen content. At the arterial level, it should be about 20%. Remembering how to do that equation, taking your hemoglobin times 1.34 times your SAT, your SpO2. Remember, when you're doing that, multiply it by 0.95. Okay, so it has to be 0.95, your decimals. Remember back in math, decimals. Plus then your PaO2 times 0.003. And when I calculated this one out, you should calculate it yourself and see if you get the same answer. I got 21.9%. Okay. All right, so that should do it for today. I will get this converted to a video file and email me with questions.